Okay, so good morning. This is Dr. Mark Friedman. I'm the Blood Bank Medical Director here at Mount Sinai West and Mount Sinai St. Luke's and the Mount Sinai Health System. And this morning we are going to be talking about a very exciting, somebody has a question already? Mic is up there, okay. So this morning we're going to be talking about therapeutic apheresis. So, the question is, what does, for those of you who have rotated through blood bank and have discussed this topic before I move on to the next slide here, what does the term apheresis mean and where does it come from?
It comes from Greek, apheresis, to separate.
Very good. So, I mean, I've heard it either coming from the Greek, meaning to take away or withdraw. Some people also attribute it to the Romans. Similar meaning. So essentially, it does mean to remove or withdraw or take away. And there are different ways that you hear it clinically. Sometimes we call it hemopheresis. Some people just shorten it and say it's pheresis, but the correct term is really apheresis. So there are different types of apheresis procedures that we have. Obviously, we can separate it into two broad categories, that being donor collection apheresis and therapeutic apheresis. Today, we're really going to focus on the therapeutic side of it, but obviously, you should be aware of the donor collections that we do. The most common product that you come across when it comes to donor collection apheresis are the single donor platelets or the apheresis platelets that we use. But there are also apheresis red cells, for example. Slides here. Apheresis red cells. You have what we call the jumbo plasma or apheresis plasma. There are granulocytes that are collected by apheresis. There are stem cells that are collected by apheresis, specialty products. So all of these products can be collected by apheresis. And typically the advantage, of course, of apheresis is that you can collect a lot more of what you want. So typically with platelets, how many more platelets do we collect than in when we're doing whole blood donation? So for those of you who went through blood bank, you should know what the conversion is. So how many more platelets do we get out of apheresis platelets?
5 times more?
About 5 to 6 times more, right? And similarly, when you're collecting red cells by apheresis, you can collect up to 2 units of red cells. There are additional qualifications based on weight and hematocrit for the donors, but if you're qualified, you can collect more red cells. So it allows you to get specialty products and more product that you want. Moving on to the therapeutic apheresis, there are different types of procedures that we do. The most common really is plasmapheresis, where you're separating out the plasma from the cells and collecting the plasma and returning the red cells. But we also have cytopheresis, which is collecting the cellular components. So in leukapheresis, we're removing the white cells. Platelet pheresis, the platelets, and then obviously an RBC exchange transfusion, or also known as erythrocytopheresis. We're removing the red cells and exchanging with healthy donor RBCs. There are also specialty types of apheresis that we do. Column apheresis, for example, the old Vascular apheresis, which is basically a staph protein A line column that can remove IgG, complexes, immune complexes. Photopheresis is another type, also known as extracorporeal photopheresis. Membrane filtration, where you're filtering the plasma. So all these different types of specialty apheresis procedures exist as well. There were, the older days, pretty much all apheresis nowadays, of course, it's an automated device that we use, and many of you who rotated through the blood bank have seen our cold spectra, although there are certainly newer devices on the market. They all basically operate on the same principle. They have a centrifuge, the whole blood goes in, it spins it down, separates it out by layers, and then based on what you program into the system, what you're interested in collecting or removing, it goes into that layer and will remove that specific component and then return the other components back to the patient. Older days, they had this intermittent flow or discontinuous apheresis, which was a single line. It's a very slow process because you have to have obviously a collection or removal period followed by a return. So it's that's why they call it intermittent. And one of the problems is because you have periods where you're removing but not returning, you do have a large extra corporal volume. So the patient can't be too anemic basically. Nowadays, pretty much everything is done by continuous flow devices, however, and many of you are familiar with this who have seen the apheresis procedures that we do. These are dual access, so either you have two different lines, or more commonly we use one single line that has double, two ports, one that removes and one where you're returning. And these allow for quicker procedures and minimal, and it minimizes, of course, the extracorporeal volume that the patient has to deal with. So these are some of the devices: the Coke Spectra, the Fresenius. There are others out there nowadays. And the way it operates, as I mentioned, it uses a centrifuge to separate the blood components in different layers. The more dense ones settling to the periphery, versus the less dense plasma. And then you also have to add an anticoagulant to the system, because obviously if you take out the blood and put it into the centrifuge, it's going to turn into a big clot. So we do add usually a citrate, so that to prevent clotting of the blood as it's flowing through the system. Of course, citrate has its own complications. What's the main issue with citrate when we use it?
Calcium.
Right, so basically it's your calcium level, hypocalcemia, but potassium, or magnesium rather, is also lowered by citrate as well, so you get hypomagnesemia and low calcium as well. So usually we do check the calcium before we start the procedure and monitor the patient for calcium during the exchange, because obviously if they become very hypocalcemic, it can have very bad effects. They can get muscle spasms and tetany, arrhythmias, seizures even, so it can be very bad. Usually it starts off with just a tingling around the lips and the fingers, and mild, but can become more severe. So you may need to have calcium supplementation during the procedure. And then, of course, all the systems require this prepackaged disposable sterile bags and tubing, the software that we put in, so that everything is sterile and clean and safe for the patient. So one of the mechanisms of actions for therapeutic apheresis, reduce the patient's load for pathologic substance to levels that will allow for improvement. So if you're removing antibody, either IgG or IgM or immune complexes or other things that you're removing, which is easier to remove, IgG or IgM? No.
IgM.
Yes, why?
It's more larger.
It's larger, it's a large pentamer, which means what?
Stuck by the fructose.
Well, then 90% of it is intravascular, whereas IgG, the distribution is what?
Just tissue.
About half of it is extravascular, right? So what happens is when you remove IgG, you can remove the intravascular, half of it, but then you get the extravascular, intravascular flow, redistribution, and that's why it's harder to remove IgG than it is IgM. That's why when you're dealing with hyperviscosity due to Waldenstrom's macroglobulinemia, for example, it only takes 1 or 2 treatments to significantly improve the patient because you can remove a lot of IgM. But when you're dealing with some of these IgG-related conditions, we do typically 5 or 6 or even 7 treatments because you have to do them to do more of them to get the IgG out. So other proposed benefits are alteration of antigen-antibody ratio, modification of mediators of inflammation or immunity, clearance of immune complexes, or replacement of a normal substance that's lacking. So, for example, a thrombotic thrombocytopenic purpura, what are we replacing? The Adams 13 and metalloprotease enzyme, right? That feeds von Willebrand factor. So this is out of the textbooks. It was mentioned that for any disease, there is a limited number of treatments that are known to be effective. When those fail, the physician has to consider alternatives that are either new and unapproved or ancient and of uncertain benefit. Patients can become desperate. And then Van Bacchus in 2000 wrote, because of the wide spectrum of the natural history of most diseases in which therapeutic apheresis is used and the variability of an individual's response to an intervention, it is often not possible to say, based on uncontrolled clinical observations, whether TA has made a difference to outcome. So these statements come into play because it's true that we do use a lot of times we do therapeutic apheresis for conditions where we don't really know what the benefit will be. So how do we categorize or classify conditions that we treat? For those who've gone through the blood bank and have covered the topic, so how do we classify them broadly?
Class 1, Class 2.
Exactly. So there are 4 classes, right, that they are classified into. And what does Class 1 mean?
Which proven benefit.
Right. So Class 1, Category 1, right, are the disease entities like TTP, like Guillain-Barré, like good pastures, under certain conditions, where we know it has proven benefit and where it can be a first-line treatment. Category 2 diseases are those where we use it, it has shown to be a benefit, but it's really just an adjunct treatment to the first-line treatment. And then when you get down to the Category 3 diseases, those are the ones where, there's some scattered case reports, of patients, getting some benefit, but it's really, there's really no good studies to show, to prove that it's beneficial. So really, usually you're using it in those cases as a last resort where all other treatments have failed. And then we have the Category 4 diseases, like lupus nephritis, for example, or schizophrenia, where it's been tried, but it's not proven to be of any benefit. Here they're talking about. We'll get to the categories in a little bit. There is a slide on it, but before we get there, so talking about now about the replacement fluid. So what are our 3 options for replacement fluids? Obviously, one is the crystalloids, which is basically normal saline. We don't really use a lot of normal saline because if you don't have a colloid, you're not going to maintain your so-called Stark forces, right? Your isotopic forces, and you're going to get a lot of third spacing and peripheral edema. So you can use some crystalloid, but certainly you cannot use all crystalloid. So what are our other options?
Plasma.
So you can use plasma, right? And what's the benefit of using plasma?
Well, coagulation factors.
So it has coagulation factors, right? One of the coagulation factors that we efficiently remove happens to be fibrinogen, because it's a large molecule, long half-life, and it is very efficiently removed. And so for those who have gone through our blood bank rotation, you know that we always do typically check the fibrinogen at the start of treatment and usually prior to the subsequent treatments, particularly if we're not using plasma replacement. So one of the benefits of using plasma is that it does have the coagulation factors and you are maintaining the patient's coagulation status. This is particularly important in patients who have either bleeding conditions, for example, if you have good pastures with alveolar hemorrhage, diffuse alveolar hemorrhage, or in patients who might, be preoperative or postoperative. It's important to maintain the coagulation status to prevent them from bleeding. So that's certainly one benefit of plasma. Other benefits?
Would be the oncotic.
So maintaining oncotic pressure, right? What else?
Less volume required.
Not necessarily, right? We'll get to volume, how much volume you're going to replace. I mean, you're typically doing the same volumes in your treatment. But the other main thing is that if you have to replace, like Adams 13, right? So anything else you have to replace. What's the disadvantages of using plasma?
Reaction.
So you do tend to get more allergic reactions with plasma. Now there are some specialty types of plasma which is supposed to be less allergenic. For example, they have a solvent detergent plasma out there now, which is a type of plasma. It's actually a pooled plasma. They take it from thousands of donors and they sort of mix it together by ABO type, and then they dump in this solvent and detergent chemicals, which sort of cleanses it. It kills the bacteria, and really it's the lipid encapsulated viruses, HIV, hepatitis, so forth, that it knocks out. And it's supposed to be a safer type of plasma, but also reportedly has less allergic reactions. So other disadvantages of plasma.
Small number of RBCs left in the plasma product can cause a reaction.
We don't typically think of plasma as being a cellular product because the freeze thaw usually knocks out red cells and things.
Infection, more risk of infection.
So exactly. So that plasma basically has all of the risks of a transfusion or transfused product. So you can have infections, you can have trolley. It also has to be ABO compatible. Don't forget, right? So that's another issue, particularly if it's an AB type of rare patient and you need lots of AB plasma. That could be a problem. So minor side hemolytic reactions could be a problem. So certainly, transfusion reactions or transmissible diseases could be an issue. And then of course, it's of course more costly than crystalloid. So plasma is certainly another option. And then what's your third option? So you can use albumin, right? Usually we use 5% albumin solution, and of course the advantage there is that albumin, yes, it is a donor product, but it's highly purified and treated, so that you have far less risk, almost no risk of transmissible diseases, and allergic reactions are minimal. It still has a cost to it, about the same as a plasma unit, but you also don't have to worry about ABO compatibility. Trolley has never really been a risk with albumin solution. So typically, we try to use albumin with or without saline as much as possible. But there are certainly certain situations where you have to use plasma, either because of coagulation status or because you're treating something like TTP, where you have to replace the Adams 13. So those are situations where you would need to use plasma. And of course, one of the other disadvantages of albumin is that it doesn't have any of the coagulation factors, right? So albumin, isooncotic, no low hepatitis risk. It does have a significant cost to it. There are no coagulation factors or immunoglobulins. And sometimes you run into availability issues. For the most part, it's typically available. And then you have the fresh frozen plasma or cryodepleted plasma or solvent detergent plasma or other plasma. Again, you can maintain levels of coag factors and immunoglobulins, but there are infectious disease risks, higher cost. There's additional citrate in the bag, so it's additional citrate reaction, allergic reactions, and other risks like trolley, for example. And then here we just mentioned the solvent detergent plasma, as I mentioned. It's a little bit more expensive than plasma. I wrote not available. That's actually not true. What happened was there was an earlier version of the product that came out many years ago that was withdrawn from the market because there was a higher risk, something in the way they manufactured the product, but they felt there was a higher risk, particularly to patients with liver, problems, liver failure patients. Now the product has been reinvented, and Octapharma has come out with their Octaplas product, which was widely available in Europe before it came to the U.S. But about, I want to say about 5-6 years ago, it came back to the U.S. and is now available as Octaplas. It's just a different manufacturing product. The way they manufacture it is a different process than the older SD Plas, or Plas was called like SD Plas Plus or something like that. So there's no issue with liver failure patients. So we talked about volume. So typically we do 1 to 1.5 plasma volume removal, which is about 40 to 60 mLs per kg in the average size adult. And one volume removes about 60% of patients' plasma, native plasma. When you get out to 1.5 volumes, you're doing about 80% removed. So why don't we do like 2 to 3 volumes? It seems like the more you remove, the better, right?
After a certain cycle, the coefficient is free, so it doesn't make a difference.
Yeah. So what basically happens is that it plateaus, right? So because now once you start getting out to about beyond 2 and plasma volumes and beyond, you're basically just replacing what you've already replaced, and you're just then at that point not really removing anything more. And you're just prolonging the procedure and exposing the patient to more citrate and more risk for complications. So that's the reason that we typically target between 1 and 1.5. Rarely we may go out to 2 plasma volumes if we want to do very large volume. For example, in a resistant TTP patient, I've seen that done. But usually we're targeted to somewhere between 1 and 1.5 plasma volumes. So that usually in a typical average size adult will come out to anywhere between 2 to 4 liters exchange. So efficiency is based on the following assumptions: the patient's blood volume does not change, mixing occurs immediately, and there's relatively little production or mobilization of pathologic material during the procedure. So, as I mentioned, IgG is particularly hard to remove because you do have that extravascular to intravascular shift, but you also have a tendency for rebound production. So it's been noted that what happens is you remove the IgG, the plasma cells become, the lymphocytes become sort of turned on or activated, and they start, producing a lot more of the antibody. So sometimes what ends up happening is you did a procedure, then the next day you recheck your IgG level or what you're trying to remove, and it's like just as high as what it was before you started, and that's because you do have that shift, and you may have also had activated the white cells, the B cells, to produce more of the antibody. So things we can efficiently remove with plasmapheresis, 75 to 80%. Fibrinogen, as I mentioned, is a large coagulation factor that we can efficiently remove, which is why we use it sort of as the canary that we, to measure, to see the status of the coagulation factors. What do we typically use as a cutoff for fibrinogen, where we wouldn't do it unless we're replacing with plasma? 100. Usually, if it's an inpatient, we'll use 100 milligrams per DL. If it's an outpatient, we might use something more like 150. But you do have to be careful. Like if you happen to be doing a procedure in a pregnant lady for whatever reason, understand that fibrinogen is an acute phase reactant, and in pregnancy, the fibrinogen is typically higher. So 100 would be very low in a pregnant lady. Typically, they have levels that are higher than 200. Fibrinogen does typically take about 3 to 4 days to recover. However, that said, I have seen it recover quicker in some of these patients. I've seen dramatic drops in it. And then, so one of the things tricks we do is we space it out. We're not replacing with plasma. Typically, instead of doing daily, right, we do every other day. So, for example, if we're treating something, I don't know, like myasthenia gravis or Guillain-Barré, where you're trying to remove IgG, and you're not going to be replacing the plasma, we don't typically do, Monday, Tuesday, Wednesday treatments, daily treatments. We typically would do like Monday, Wednesday, Friday, right? We space it out. Why? Because we want to give the liver time to recover and regenerate the fibrinogen. And sometimes you can see a fairly quick rebound, but it's really patient dependent. In some cases, they have small livers, or for whatever reason, they're not producing the fibrinogen, and you can rapidly deplete them, and they don't really recover, and that's when you either have to withhold the treatment or consider giving plasma. Things that are less efficiently removed are electrolytes, factor VIII, uric acid. As I said, IgG, you can remove a certain amount, but you do get that intravascular to extravascular shift. IgM also, as I said, you can fairly efficiently remove because 90% of it is intravascular. You do lose some, red cells in plasmapheresis, some platelets, not a whole lot. You can affect some of the medication levels, anything that's protein-bound, antibiotics, dilantin digitalis. Where you really have to be careful, though, is with some of the antibody-based, monoclonal antibody-based treatments. So if you're using something like rituximab, which we sometimes do for TTP patients who are very resistant, right? That's the anti-CD20 antibody. Obviously, if you give that right before plasmapheresis and then you do plasmapheresis, what's going to happen? You're going to remove it, right? It's a very expensive drug. Same thing with IVIG. If you're giving IVIG and you give it right before the plasmapheresis treatment, then you do plasmapheresis, you're going to remove it. So typically, if patients are on these types of treatments, we would consider withholding plasmapheresis for at least a day or two, so they can get the benefit of the treatment. So vascular access. So there are complications, of course, with the vascular access. Typically, we like to use central lines. Most commonly, we use IJ lines or sometimes subclavian. Femoral, in extreme cases. The problem with femoral is it's not a very clean area, and they do tend to get more complications with infections, catheter line, sepsis. But if you're doing a one-time treatment like a red cell exchange, there's nothing else. You can certainly use a femoral line. So, obviously there can be complications with that: hematomas, thrombosis, bacteremia. There can be, as we mentioned, alteration of pharmacodynamics, particularly for protein-bound, medications, or if you're using monoclonal antibody-based or IVIG, antibody-based treatments. Hypocalcemia because of the citrate, reducing the calcium. Well, same thing for magnesium. You have to, that can lead to hypotension. Patients on ACE inhibitors, particularly if they're undergoing the membrane type treatments, you can produce hypotension in those patients. So we typically, do recommend taking them off of ACE inhibitor type medications if they happen to be on it. Allergic reactions, particularly with plasma. There can be equipment failure leading to mechanical hemolysis. That's rare. You can even get air embolism if the air gets into the system. But again, that's a very rare complication because these machines have bells and whistles to prevent that from happening. Fatalities are rare. And as I mentioned, it can be from cardiac arrhythmias or arrest, typically if there's really severe hypocalcemia, for example, anaphylaxis, thrombosis, and an air embolism can also be a rare cause of it. So vascular access can be a major limiting factor for provision of apheresis. It's one of the things that, of course, would delay getting the treatment because you have to wait to get the central line placed, and it can't just be like a PICC line. It has to obviously be a dialysis quality catheter that can really withstand, the withdrawal and return of high pressure. So that's really one of the limiting factors about supplying therapeutic apheresis in a timely manner, is that there's often delay in getting the line in. And then of course it's a matter of keeping that line clean, and if it's put in, oftentimes we send them to interventional radiology to have it put in, and those lines typically are put in very cleanly, and you can even discharge patients home with those lines. Teach them to maintain, keep it dry, and they can even then come back and get outpatient apheresis. Some people also, we do it through ports. So, if you're really expecting very long-term, treatments, like we have one sickle cell patient who comes for a monthly red cell exchange, and he doesn't have very good veins, obviously, and we don't want to keep putting in central lines. So he actually has a special type of port that's implanted in his chest that we can access. But also, if you have dialysis patients, you can access their AV fistulas, and anything you can do dialysis through, you can really do plasmapheresis through, or therapeutic apheresis through. So now we're getting to the disease categories that we mentioned. There are a variety of diseases that we treat: autoimmune and rheumatic diseases, hematological and oncological diseases, renal and metabolic diseases, neurological disorders. And then these are the categories that we mentioned. Now, it says it up there, but I'll take it off real quick. Whose categories are these? Who makes these categories? So one is the ABB. Yes, the ABB does categorize them. And who's the major organization that does this? That's fine. ASPA, yes, the American Society for Apheresis. Now, here's a trick question. Where's the American Society for Apheresis located?
Manchester.
No. The American Society for Apheresis is located in
Canada.
Vancouver, BC. I believe that's where the headquarters is. This? Maybe they should call it the North American or something. Society for Apheresis. NASFA, something like that. But anyway, they're the major organization that does put these categories together. ABB does, also these categories, and they're very close to what what ASPA is. They match, but not exactly. So how does ASPA come up with these what diseases to categorize? Basically, what they have is they have a committee that looks into all these disease entities. They research the literature. They look at what studies have been done for these diseases and what the level of evidence is, and then they come out with a publication about every 3 years. Actually, it is every 3 years, where they categorize the disease entities by these disease entities by category. And they give you a whole thing of why they did that, what was their evidence. And actually, many of you, or pretty much I think all of you, have seen this publication when you've rotated through the blood bank, right? So it's a good idea to, whenever you're involved in an apheresis case, to consult that. So because that, tells you what the benefit will be. It will give you an idea of how long you should be treating, what the treatment schedule should be like, what the replacement fluid is, et cetera. So category ones, and these have changed over the years. This is a little bit older slide, so some of these things have certainly changed as they update their categories, their diseases. Every 3 years. But as you can see, some of the category ones, Guillain-Barré, certainly you can use IVIG for that as well. Hyperviscosity, symptomatic, myasthenia gravis. One of the more common ones we treat is the TTP. And you have the category 2, things like, actually HUS is still a category 2, atypical HUS we're talking about. So why is TTP a category 1, but atypical HUS a category 2?
Still on the first line, right, for atypical HUS.
Well, it really has to do with mechanism of action, right? So if you go back to the old days, everybody thought really that TTP and HUS were the same disease, but it was just a spectrum. One had more neurologic and the other had more renal. Now what do we know about the two disease entities?
It is complementary against, right? Atypical HUS.
Right, so we know that they're completely different mechanisms, completely different categories of disease. In TTP, even though they present similarly in the fact that you have hemolytic anemia with thrombocytopenia, right? But the mechanism is completely different. In TTP, it's the fact that you're lacking the Adams 13 metalloprotease, right? And most commonly it's because you've acquired an inhibitor, though in some cases there can be certainly congenital, lacking of that enzyme. In atypical HUS, on the other hand, it's really related to the deficient complement factors, and sometimes it can be due to an autoantibody or an antibody or an inhibitor that you've acquired that can deplete complement factor H, for example, or complement factor I. In other cases, there can be genetic mutations that lead to these inactive complement factors. And so, TTP, plasmapheresis is still the first-line treatment, and that's therapeutic. In HUS, on the other hand, atypical HUS, plasmapheresis really is just a treatment that can tide you over until they get the Soliris medication. So Soliris is really, or eculizumab, is a monoclonal antibody that is a terminal complement inhibitor. It actually this was first approved for PNH, paroxysmal nocturnal hemoglobinuria, which has similar mechanism to atypical HUS in that it involves terminal complement issues. So by using the eculizumab medication, you can effectively treat atypical HUS, but oftentimes there's a delay in getting that medication because it's very expensive and it's lifelong, and they have to look at the insurance company, and also because oftentimes there can be confusion between whether it's TTP versus atypical HUS, right? Until you really measure the metalloprotease, Adams 13, and if it's typically if it's below 10%, then the thinking is it's TTP, but it's above 10%. Then it leans more towards atypical HUS, provided, of course, there is renal failure there. But then they would have to send out for the genetic testing to figure out which type of, subtype of atypical HUS, which complement factors involved. And then once they do that, then, getting them off of plasmapheresis and treating them appropriately with the eculizumab. So that's why it's really, a second level. Actually, the RPGN, rapid progressive glomerulonephritis, really depends on what type of rapid progressive glomerulonephritis. Whether it's the Wegener's type or the Good Pastures type. So some of them are actually fit into the category 1. Actually, they have Good Pastures over here. But Good Pastures also depends on whether degree of renal failure. Basically, in Good Pastures, once they are on dialysis, apheresis, plasmapheresis is not much help anymore. It's really in earlier treatment, it's benefit. On the other hand, if it's Wegener's, then really it's more helpful once they start getting to more advanced renal failure and are on dialysis. Or in either case, it's helpful to use it if they do have diffuse alveolar hemorrhage. And then you have some category 3 diseases, ITP, we rarely use it for that. Others, multiple sclerosis, depending on the type, if they have the rapidly progressive type, I guess, and they're not responding to their medications, you can certainly try of course the plasmapheresis. Some category 4 diseases where they've tried ALS, psoriasis. Renal transplant rejection actually is not a category 4. It really depends on, we actually use it now to remove, if they do have based on the HLA, based rejection, you can actually remove the HLA antibodies and, help improve or reduce the rejection, save the kidney, basically. Also, if you're giving like an ABO incompatible transplant, you can try to remove the ABO antibodies before and after. And, so that's another indication for therapeutic plasmapheresis in transplant setting. Talking a little bit about TTP here, which I've mentioned before. Again, you have the classic 5 signs: thrombocytopenia, microangiopathic hemolytic anemia, fever, neurological signs, renal failure. But actually, nowadays, you only need how many of these to really make the diagnosis, or really to suspect it?
3, right?
Well, actually 2. The only thing you really need is the thrombocytopenia and microangiopathic hemolytic anemia. If you have those 2 and then they're unexplained by anything else, then you might suspect TTP as being in the differential. Of course, if you do have renal failure on top of that, then you can put in atypical HUS as well. And then the blood smear, you'd see thrombocytopenia with the schistocytes, labs, elevated LDH, low haptoglobin, which are markers of hemolysis, elevated bilirubin, of course, and then what's becoming the most important lab to make the diagnosis, which we mentioned before. The Adams 13 TS level plus the corresponding inhibitor, since most cases are acquired. Unfortunately, most labs have a delayed turnaround in getting the Adams 13 level. There are some that can get it to you within 24 hours, but most labs, it takes about a week or more to get the result back. And then the mechanism of action are these, ultra large von Willebrand factor due to the lack of the Adams 13 metalloprotease cleaving enzyme, leading to endothelial injury and subsequent destruction of the red cells as they break up when they hit the platelet clots. So a little bit more about TTP. Most cases are idiopathic, but there can be cases, that are drug related. Actually, the drug related ones now have even been separated out from classic TTP into the thrombotic microangiopathies. And then the most common one is the clopidogrel induced TMA, which to some extent might be mitigated or improved by therapeutic apheresis, but there are other types of drug-induced situations that are not as responsive to plasmapheresis. So it really depends on which drug is involved. But you also have TTP that are related to pregnancy, which can certainly overlap atypical HUS or the HELP syndrome. And then for TTP, as we said, the first-line therapy is really the plasma exchange. In the past, it was very high mortality, but now through plasma exchange, we've significantly reduced that mortality, and many patients, do end up doing well, but realize that there can be as high as a 25% recurrence rate with TTP. It's also been recommended to put them on, steroid treatment with the plasmapheresis. The idea being to try to minimize or reduction of the inhibitor level. Any other treatments are really controversial, antiplatelet therapy. And as I mentioned, relapses, can be common. Vincristine we really don't use so much for resistant splenectomy. Also, is not as commonly used anymore. Nowadays, IVIG is still used sometimes in resistant cases. Really, the treatment of choices for patients who are not treating or not responding, and you've proven that it is TTP, is to use the anti-CD20 rituximab. It's very commonly used nowadays. The role of therapeutic plasmapheresis, again, you want to start the treatment as soon as possible. Daily TP until you get the platelet count, typically in the normal range above 150,000. And typically we would do that, continue the daily treatment so that until the platelet count, has stabilized for like 2 to 3 treatments. And then you can, in many cases, you can abruptly stop the treatment, although some still recommend the taper type of thing where you're going from every day to every other day to every third day and then stop it. But one of the foremost experts in TTP has got a very large TTP registry out in Oklahoma is Dr. James George, and his recommendation is basically to treat daily until you get the platelets above 150,000 for 2 to 3 days and then just stop. So your replacement fluids is you have to use plasma in some form or another because you need to replace the Adams 13, whether that's the FFP, the cryopore plasma, or the SD plas, octoplas. All of them have Adams 13, so that you can use any of those. In the older days, they talked about plasma infusion versus therapeutic plasma exchange. I think this is sort of an old concept. It's long been known that with plasma exchange, you can more effectively treat the patients, prevent volume overload, and give them higher, more plasma exchange. Let's see. All right, so Guillain-Barré syndrome or acute immune demyelination, inflammatory demyelinating polyneuropathy, rather. So this affects about 2 per 100,000 persons yearly. Patients present with weakness, paresthesias, in an ascending symmetrical pattern. May involve, in the more severe cases, of course, you can involve the respiratory muscles, and that's really the most dire situation in these patients. So we can treat this with plasma exchange, although also IVIG is another popular treatment. So the role of therapeutic plasmapheresis, it's been well studied and shown to be effective in treating the patients, provided that you get them early. Typically, it's most helpful if you start within the the first 2 weeks of onset, because really once the damage is done, you're not going to reverse the damage. It's the idea that you're removing the antibody and preventing progression of the disease. But it has been found that starting early, you can get them out of bed and walking sooner and prevent pulmonary complications. So typically, with plasmapheresis, we usually exchange with albumin. But again, you do have, if you're using albumin, you want to space it out every other day, and of course measure their fibrinogen and P2-PTT to make sure that you're making them, not making them hypocoagulable and exposing them to bleeding risk. Multiple myeloma, there are several situations that we can treat with myeloma. One is hyperviscosity, particularly in Waldenstrom's, if they get accumulation of these large IgM, and they're almost all intravascular. They can get the hyperviscosity syndrome, which is classically marked by bleeding diathesis, mental status changes, and retinopathy. So you can, effectively remove the IgM and treat the hyperviscosity. But in IgG type of myeloma, they don't get so much hyperviscosity as they do renal complications. And usually the renal complications often occur because of the light change, the Bence-Jones proteins. So there is some thought that you can do plasmapheresis to remove the Bence-Jones proteins from the kidney and improve their renal failure. There is some controversy surrounding it. Some studies show that it is effective, and others show that it's not so effective. In our own practice here, I've done it a few times. Not much benefit in the patients, but still, we do offer it for patients, who have a so-called myeloma kidney. Red cell exchange. So red cell exchange is most commonly done for sickle cell patients with severe crises, most commonly if they have acute chest syndrome. Although, also if they have a history of stroke or other severe crisis, you do a red cell exchange. And what the red cell exchange does very effectively is it can effectively remove the hemoglobin S and replace with hemoglobin A. And typically the goal is to, reduce your hemoglobin S below 30%, while maintaining the hematocrit, not higher than 30% in these sickle patients, because, you don't want to make their blood too thick. The other benefit of red cell exchange is that it also prevents iron accumulation. So if you do have a patient who's on chronic red cell exchange, one of the big benefits is you can maintain a hemoglobin S low, hemoglobin A high, and also avoid too much iron accumulation, which is problematic in chronically transfused patients. Other reasons to do red cell exchange could be in patients with severe parasitemia, for example, patients with very high malaria, or severe malaria, or that's affecting cerebral malaria, or even in babesiosis, for example, if they have, complications with babesiosis and they have a very high parasite count, or in patients who might be asplenic, and, those patients could be at very, high risk for dying from the parasite. So you could do, red cell exchange in those patients. It might be a benefit. We have a few minutes left, so let's see. So the advantage is when you're looking at a sickle cell patient and considering simple transfusion versus RBC exchange. What are the things that would sway you one way or the other? So in simple transfusion, obviously it's easier to do because you don't need a special catheter or device or apheresis nurse. And you can certainly raise the hemoglobin A, but you also raise the hematocrit significantly, which could put the patient at risk. You also tend to get more iron accumulation that way. Whereas in exchange transfusion, you can rapidly, not only raise the hemoglobin A, but you're reducing the hemoglobin S, and you can maintain the hematocrit at a desired level. Typically, we don't want it to go higher than 30% in a sickle cell patient. And here, the goal of transfusion therapy in sickle cell disease is to keep the hemoglobin S below 30%. And as I mentioned, the hematocrit, you typically don't want to go above 30%. Let's see. No, that's my last slide. Okay. So again, there are certainly benefits to doing red cell exchange in sickle cell patients, but it takes a little bit more planning. So overall, when you're considering doing therapeutic apheresis for anything, so what are some of the things you have to think about? Obviously, you have to think about, what is the condition that you're being asked to treat? Is it treatable by therapeutic apheresis? What type of therapeutic apheresis? We didn't really get much into platelet pheresis or granulocyte apheresis, but those, there are certain situations where you have to do remove platelets or white cells. For example, in a patient with acute leukemia who has a very high white count, could put them at risk, for hyperviscosity and stroke. You may need to, come in, and particularly if their WBC count is greater than 100,000, and particularly if they have a large number of the immature granulocytes, because those are the ones that are very sticky and can cause neurological complications. So that might be an indication where you have to do a granulocyte apheresis to rapidly reduce the white count. Additionally, in platelets, typically when the platelets get above 1 million, for whatever reason, they could be at risk for stroke or symptoms of the hyperviscosity, and you may have to come in and rapidly remove the platelets, reduce the count. So those are situations where we might do platelet apheresis or granulocyte apheresis. But things that you have to think about when you're doing it. So one, you have to think about what condition are you treating and what type of apheresis are you going to do, whether it's a site apheresis or it's a red cell exchange or platelet apheresis or plasma apheresis. And then you have to think about what will be the benefits of the patient, how many treatments are we going to offer, is it a one-time thing or do we need repeated treatments? How often are we going to do the treatments? Is it daily? Is it every other day? What are the, what type of line placement will we get? How quickly can we get the line placement? What about replacement fluid? Obviously there's certain situations where, as we talked about, where you need to use plasma versus albumin. What about getting consent? Is the patient in a state where they can give consent? Obviously, if it's an acute TTP and they have mental status changes, or they're in very bad condition, they can't give consent, so you need to get family consent. So all of these things really need to be, considered. Also, how urgently is the treatment, needed? It's one thing if it's really an acute, TTP with neurological symptoms, you need to come in as soon as possible. Or in a patient who might have, a very high white count, where they're at risk for stroke, or a very bad sickle cell patient, you might need to come in, as soon as possible, even overnight. Whereas other patients, they've been hanging out for some time and not so severe, we can, push it to the next morning. So those are things to think about as well when you're considering it. Other things we didn't really touch on is some of the specialty types of apheresis, like the extracorporeal photopheresis. They do actually do that procedure at Mount Sinai, for typically for patients with transplant rejections, or who have graft versus host disease. They'll do a case of treat the patient with the photopheresis. So what photopheresis does is basically you remove a portion of the plasma and you treat it with an activating compound, a light activating compound like seralin or methoxyseralin, and then you zap it with UVA light. And what basically that does is it cross-links the DNA, and it basically knocks out lymphocytes or T lymphocytes and can prevent, for example, graft versus host disease or treat graft versus host disease from happening. And then you reinfuse those, and for some reason it has more of a systemic effect, even though you're only treating a portion of the plasma. And you do a few treatments of photopheresis. So that's a specialty type of apheresis. Another one is the liposomal column, where you can actually treat patients with type 2 familial hypercholesterolemia who are not treatable by diet or medications. You can go in and use this column to remove the LDL cholesterol and reduce their cholesterol load. So that's another type of specialty apheresis that's available. So are there any questions? Everybody's an expert now in therapeutic apheresis. So one of the things that we do nowadays is that, we do get occasionally some treatments here in the hospital, but, certainly we want we're now sending the residents up to Mount Sinai for a week to work in the outpatient apheresis clinic up there. So when you're up there, you'll see a variety of cases, patients coming in for, plasmapheresis or photopheresis, stem cell collections that they're doing. So you get that experience.
Thank you.
All right, thank you all.
Thank you.
Thank you, Friedman.